All right. Good evening, everyone, and welcome to the 9th of November installment of the National Fellows Online Lecture Series. I'm Julie Creech. I'll be your moderator this evening, and our presenter this evening is Morteza Khodaee, as he's going to speak to us on lower extremity dislocations. Before we get started, I just want to go over some of the ground rules. We do ask that everyone in attendance mute their microphone and turn off their camera throughout the duration of the presentation. If you do have any questions that arise throughout the presentation, please feel free to submit those in the chat function, and we'll review those afterwards during the question and answer period. Additionally, we do recommend that you stick around and look out for that chat function at the end. We'll be sending a link to a survey where we just ask for your feedback on how we continue to shape these lectures to better meet your educational needs. So now it's my pleasure to introduce our speaker this evening, Dr. Morteza Khodaee. He is a family physician, sports medicine physician, and faculty physician out at the University of Colorado. He did his residency and fellowship training at the University of Michigan, and he is more than qualified to teach us this afternoon or this evening on lower extremity dislocations because as part of his job, he works out at a ski clinic in Colorado. So he has certainly had a lot of great hands-on experience with these dislocations. So it's without further ado that I will turn the screen and the mic over to Dr. Khodaee.
Thank you so much, Julie. That was very nice of you. Let me just try to share my screen. Just a second. Can you see my screen?
Yes, sir.
Okay. So I would like, the fellows, I think, these are the stuff, probably you are not going to see during your fellowship. And sometimes it's very difficult to see it. But these are the conditions you need to be very aware of, when to interact and when to manage, and when you just basically, you need to just call 911. I think, sometimes, these are not very common, some of them, to see in your regular practice. So I think, but they're very, very important to know how to deal with them. So we go through a few of them. I have nothing to disclose. The important part, is just, what are we trying to get out of this is, hopefully we can recognize some of the most common lower extremity dislocations and determining how we should manage them. This picture, all the picture you see on my presentation, these are all my own patient, unless there are some of the images I didn't have them, so I have this citation underneath that. So those are not mine. So this was a patient that came out of the ski clinic with a huge hemarthrosis, and we'll discuss the possibility what can happen. Also, hopefully we can just people after the presentation just know what appropriate physical exam they can do, and also some of the reduction techniques we can just discuss that. Evaluation, again, very, very important to do any types of acute or chronic condition you see in your patient, how to do evaluations. The most important thing I would just I don't know how I can just emphasize this enough, is you ask question what happened, because if you know the mechanism of injury, I think this is very important, gives you a lot of information. Was it any direct trauma, was it indirect trauma, and nowadays most people, they have the camera, and they show you a video, I think, oh, this was happening, but also you're covering a football game. Sometimes, if this is a nationally televised or somebody's videotaping, you can just go and try to just go back and to see what happened. These are very, very important to know, at least, the mechanism of injury. Try to expose the part is the problem. You need to just, cut the ski pants, whatever you need to do, you need to just see the extremity completely. You cannot just do your exam over like football equipment. We are talking about something serious. Obviously you have somebody with ankle sprain, you're not going to go just cut their all the clothing they have. This is just mainly for something you're concerned about, something more serious. And try to just see if there's any skin disruptions, if there's any deformity you can see. Very important to just check for neurovascular status, check for the distal pulses, for sensation, cap refill, and also ask for some types of motion. And your physical exam obviously is a very focused physical exam. It is very important to use personal protective equipment. The picture in the right is semifinal of World Cup a few years ago. And you can see the doctor and the trainers, they obviously do not have any gloves. Yeah, and there's a scalp laceration, and you can just see they're using their bare hand. Try not to do that. You can easily grab gloves to do that. On the left side, this is a patient, was mountain biking, and you can just see how the helmet. Imagine if he didn't have any helmet, so what would have happened with the branch, he went into. So you can just see this, it's a video of just the doctor just stapling the laceration with bare hands, basically. Try not to do that. Just make sure you protect yourself as well. These are potentially lower extremity dislocation, but I guess, spine and SI, they're not technically lower extremity. And the symphysis pubis in general, probably not. And usually we see them in severe trauma. We got to focus on 3 areas, hip dislocation, knee dislocation, and ankle dislocation. How about you see somebody with open dislocation? So what do you do? This is not, again, a patient of mine. I just got it from the reference below. So by definition, if there is any skin break, does not need to be the bone sticking out. So that's an open fracture or open dislocation. In this case, there's no fractures, as you can see on X-ray. So this is an open dislocation. So when you have this, obviously there's a risk of contamination, infection. You have to take into account and try to just control the bleeding. Oftentimes there's not that much bleeding, but if there's any active bleeding, you try to just put some pressure, just decrease the amount of bleeding. Try to cover the wound with a moist, sterile dressing. Do you reduce it or not? We'll discuss about that. But most of the time, if you can gently reduce it on the field, it's reasonable to do that. And also it depends on your comfort level. You've done it before or you feel comfortable. The thing, I want to just make sure if you're not doing any X-ray, you don't have any access, don't try to prove to yourself or people around you you can do this. So think about this: the patient is not under good anesthesia. Thinking you do not want to just create more harm. So try to just if you wanted to try it once gently and see if it goes in, I think you can do it. Otherwise, I would not recommend trying that. And try to splint it and stabilize the part of the body was being dislocated. And as soon as possible, you have access to some types of IM or IV antibiotics. You should start that and make sure you cover gram-positive and gram-negative bacteria. We usually use like first generation cephalosporins. That's a good choice. Make sure the tetanus status is up to date. And transport them by an ambulance or a private vehicle if you don't have access to that or is not available. Remember, this is not super urgent. As long as you can do it within 6 hours, I think would be reasonable. But obviously, the sooner you do that, the better. The patient would be in better control. This is for all for open dislocation, and they are usually common in lower extremity digits. Other than that, and patellar dislocation is very rare. Ankle dislocation, we'll discuss that. That is also a possibility. Again, we talked about neurovascular compromise. You check for distal pulses, sensation, motor function, cap refill, and these they need to be transported as soon as possible. You cannot wait for this. Should be some limb-threatening condition, and if you can again reduce it with or realign it, the limb with gentle maneuvers, I think you should try that. So reduction or not reduction on the sideline. So this is a patient of mine, was a friend, called me, said, oh, I think there's something happened to my knee. I just went there and I saw that. Okay, so obviously you can just see this right kneecap, right patella is dislocated laterally. So the question is, should you reduce it or not? We were at his home, so obviously I did not want to just, hold it and just go to the ER, just get an X-ray and do that. So I attempted to reduce it, and I reduced it right away. And you can just see there's some hemarthrosis and happening. So the bottom line, the point is, if you're able with gentle maneuver, just reduce it. I think, any dislocation you have, I think is reasonable to do that. I have a couple practical points for that. Right now, all of us, we have a camera, we have a phone. Try to take a picture before and after. Not just necessary for legal purposes, which would be helpful legally as well if something goes wrong. Also for communicating, imagine you send this patient to the ER and then you tell them, oh, this was a knee dislocation. They're not going to believe you. Said, oh, probably that was a patella. But if you have a picture, I think, would be very, very helpful to show the ER facility. I think, what happens. So I think try to just take pictures and would be very, very helpful in terms of the care and the clinical care of that specific patient. And why do we just, what are the value of just immediate reduction? Obviously, when you reduce it sooner, it would be less difficult because the muscles are not started contracting and just having spasm. So it would be a little bit easier to reduce it. Also, because you don't have any edema yet or any hemarthrosis, probably would be easier to do that. And they get pain relief. Patient get significant pain relief after reduction. Also, you can keep preserve the skin vascularity, decompress the neurovascular compromise structure, and also is much easier to transport the patient and put them in a splint. This is again, this is not my patient. You can just see multiple metatarsophalangeal joint dislocations. These are usually happens with high-speed sport or more vehicle accident. What are the problem with the delayed reduction? So obviously, patient developed a significant amount of pain. They develop muscle spasm. They also is much more difficult. They may have some compromised neurovascular structures, and they most likely would need more anesthesia for reduction. And the transportation of the patient also would be very difficult because patient is in a lot of pain. Disadvantage of on-site reduction, usually, as we talked about it, we try not to do harm. Sometimes if there's a displaced fracture or in addition to the dislocation, you can create damage to the soft tissue and damage to the neurovascular structure as well. And you may create some damage to the joint as well. And the other thing, we don't have X-ray. We don't know if there's any concurrent fracture present or not. I think these are, and also you don't know sometimes the dislocation's direction. It would be hard, and so that's why I think if you want to try it once or twice, I think it would be fine. Other than that, it's best to just have documentation of X-rays. Would be very helpful. I think we're going to talk about a few cases here. I think cases, I think it's easier to just discuss. So this is a patient I was in the ski clinic, and a 29-year-old gentleman, he was snowboarding and he fell. And he came with his friend, and his friend said, he overshot landing when he jumped, and had a significant amount of pain in his right hip, and he was not able to walk or put any weight on his right lower extremity. He was brought down by ski patrol, and as his friend had the camera, so we have exactly what happened. So I'm going to show it to you. So as you can see, the mechanism of injury not always typical. So I think I'm going to show it one more time. They were just going up, and he's landed on his basically torso, upper back. But the amount of momentum creates a lot of significant torsion on his body. So that's him. So and what you can see here, first of all, he was neurovascularly intact. He was at least we were able to feel pulses, and sensation was fine, was able to wiggle his toes. He was not able to move his right leg. So again, if we were in person, I would have asked, what do you think is going on? But obviously, I cannot do that. But this patient, as you can see, is the right lower extremity and right hip is internally rotated. So then we just went quickly to the X-ray, and again, I could have asked you a question, what do you think is going on? But it's hard to do that on Zoom. So left hip looks pretty good. Right hip, as you can see, the femoral head is not sitting in acetabulum, so I think it's just dislocated. It's completely dislocated, and is it anterior or posterior? You can just see based on this, this is a posterior dislocation. As oftentimes you need to have multiple views. But also because of internally rotated, this is more consistent with posterior dislocation. As you know, posterior hip dislocations are more common than anterior dislocations. These types of injuries can happen in sports like, high-speed sports like skiing, snowboarding, motor accidents like motorcycle, car accidents, also the dashboard types of injury, people just getting an accident and knee just hit the dashboard and posteriorly pressure the acetabulum and can have posterior dislocations. How do we reduce them? First of all, requires a lot of force to dislocate hip. So for that also requires a lot of force to put it back. So it's not very easy to do that. I have never seen or never heard anybody reduce, at least in our clinic, without completely conscious sedation, a hip dislocation. So for that, we need to patient needs to be completely out. Obviously, for lots of reasons, patient is more relaxed. Also, we do not want the patient to suffer a lot of pain and discomfort when you're trying to reduce it. So obviously, you do x-rays, look for any specific or any significant fracture with this. And you need multiple people for reduction. So the goal is somebody needs to stabilize the acetabulum, and somebody needs to move the femoral head anterior, and also sometimes you have to do a little bit of adduction and abduction, multiple maneuvers. I just want to simplify it, and remember this requires a significant amount of force. You need to be very, very strong to do that. So this is one of my mentor, Dr. Hill, and he's doing the reduction. Another patient is completely with propofol, completely consciously sedated, so I think he's not patient feeling anything. And Dr. Smith, one of our attending, also can just both of them here doing that. So you see that Dr. Hill is standing and just on a table and just trying to just have Jack is just holding the acetabulum, and that just reduced. I'm going to show you one more time. So again, significant amount of force requires that. So two people are just stabilizing the acetabulum, and just a lot of anterior force. You can just see 1, 2, 3, and that just reduced. And after reduction, you just put it in you try to just stabilize it, and then you have to get a post reduction imaging. So this is another patient. So you see that we have 5 people, and then so the first one will be sometimes people feel a little bit click, the thing is reduced, but it's not. Look at here, 1, 2, 3, and reduced. So again, significant amount of force you need, and you have people stabilized. So obviously the patient is completely, and to see that patient, one of the nurses trying to check the breathing and respiratory, because use propofol or ketamine sometimes. We need to just make sure not everybody just focusing on the hip. You need to have somebody focusing on patient is breathing. Sometimes you need to just bag them for a short term as well. The good news is that medication with a very short half life, and just gets out of the system very quickly. So we did post reduction X-ray. You can just see it's pretty good here, and it's a very small area here. I'm going to show you. There's a small avulsion fracture. So again, it's not uncommon, and you can just see it on this 3D CT as well. it's not uncommon to have fracture. Majority of the hip dislocation, there are acetabular fractures. And even if you don't have any bony fractures, it is very common to have labral tear. Depends, how much symptom patient has. For follow-up, they may need to do advanced imaging, including CT or MRI. What do you do after the reduction? Obviously, it's the best not to just advise them not to put any bear any weight. It is not a joint after dislocation. It's after reduction, it's going to dislocate easily, so you don't have to be worried too much about keep them in a specific posture. But I think they have to be very, very careful, and you can start range of motion in few days. Having said that, I had a patient, I think the one I was there and just reducing this, the patient after came back out of conscious sedation, she said, I have no pain, and she started walking, and she said, should I walk? I said, I don't recommend, but you have no pain. We didn't use anything like intra-articular. So I think people can be different. So I think I would cautious people not to be very aggressive, but you can use pain, how much pain they have in terms of how much they can do right away. But obviously, there are lots of ligament tear happening with that, so you have to be very, very careful, and they need to have a follow-up. And few things is basically differentiating between posterior and anterior hip dislocation. Usually patients with posterior dislocation have internally rotated and shortened lower extremity. As we talked about it, oftentimes you need sedation for reduction. It's not easy to do it without that. And also make sure you just stabilize the pelvis during the reduction is very, very important, because if you move both parts, it's not going to get reduced. Okay, second patient. This is a patient with a knee. So it's a 21-year-old soccer player, was trying to dribble and cut quickly and pass the player and get immediate left knee pain. He goes down and just, the trainer goes there and he's unable to bear weight, and he's in a lot of pain, and he's also unable to flex or extend. So probably you already know the diagnosis, but I'm just going to show the picture. This is the picture of the patient, and see it has limited range of motion, and neurovascular, he was intact. Obviously, on your evaluation, you can just see here something is deformed. So most likely, you all guessed it correctly. So this is a lateral patellar dislocation. So we did x-rays, obviously, and at the time, because we had access to x-rays right away. And as you can see, is obviously patella is laterally dislocated in AP and in also sunrise view. So how do you reduce it? This probably one of the easiest reduction you do, but remember, this is not for your satisfaction to just do it quick and just feel it clunk, because you have to be super, super gentle. So what you do, just very slowly extend the knee. Usually the knee's in a flexion, and you may need to a little bit lateral push, but you don't need that much. You can just see in like a few seconds, it's going to go in very gently and just goes in. So again, you do not want to feel a heel clunk, because that means sometimes you can create more trauma, more damage, so more injury. So try to avoid that. I'm going to show you that last part one more time. Again, very gentle. With you try to just extend the knee, and very gentle motion. You can just push it back, and it goes back. So it's back. You can just see. Should you do X-ray? Absolutely. First of all, to confirm is reduced, and also a significant number of people, they may have avulsion fracture, or they can have osteochondral fracture. For that, oftentimes you need to do a tunnel view, if you're thinking about it. That is specifically for femoral condyle, but if you have osteochondral behind the patella or in the anterior part of the femoral condyle, I think you should be able to see it in lateral or sunrise view. So this is another patient. I saw actually this patient about 2 weeks ago, non-contact, first time primary patellar dislocation. in a 47-year-old gentleman. And as you look at it here, and he said he was basically reduced it by himself. It was self-reduced after some maneuvers he did. And when you look at it here, nothing looks like very unusual, but if you pay attention a little bit here, there's a small amount of avulsion fracture. So you can just see it. Sorry, you can just see it here. So this is the location of the medial patella. That's the location of your medial patellofemoral ligament attaches there. And if you remember, when you have a dislocation, that ligament cannot be intact. So most likely it's completely torn, or at least significantly have partial tear. So it's not going to be a complete. And sometimes that could cause some avulsion fracture as well. So when you see them in clinic, that is the key, is you need to do an X-ray. You cannot just say, oh, you're fine. This is the same patient. As you can see, let me just move this. As you can see, in the MRI, we did an MRI because patient was in a significant amount of pain, had a little bit indentation here in the femoral condyle. That's the location of the patella was sitting there. So you can just see that. Sometimes this creates significant and big piece of osteochondral. Sometimes it doesn't. So the key here is also patellofemoral dislocation or patellar dislocation usually creates significant amount of hemarthrosis, is one of the condition that can happen. So this is another patient, 14-year-old gentleman. He had non-contact patellar dislocation, first time primary dislocation. And as you can see, significant amount of effusion in MRI. And also look at here, this is the medial patellofemoral ligament. And you can just see completely wavy and had a rupture of the ligament. Okay, so the question is, you have this, what do you do? First of all, if the first time happening, you do not need to be aggressive in terms of send them to the surgery. But oftentimes, if this is secondary that has happened multiple times, they have now instability. So then you have to send them for orthopedic surgeon referral for evaluation of possible surgical intervention, and that may be needed. Or sometimes they have huge, significant osteochondral defects. They may need to get surgery to fix that. So the other question is, it is not a bad idea to, let me just, sorry. What are my slides? I think I don't. Oh yeah, I think this was it. So, but why do we have this? And some people they can have trochlear dysplasia. So the femoral groove is very shallow, that they are much higher risk of developing patellofemoral instability and dislocation. So that's why I think, when you do X-ray, make sure you can evaluate for that as well. So what do you do after reduction? That's the same gentleman, 14-year-old, you can see significant amount of hemarthrosis. And should we aspirate that? Absolutely, because that creates significant amount of discomfort. So we just aspirated significant amount of blood from the knee, and patient felt much better. Obviously, use a local anesthesia just for that, and put them in a knee immobilizer, and X-ray absolutely needed. If you're concerned about something else, MRI in the next few days also would be appropriate to do that. And weight bearing and partial weight bearing, would be appropriate based on patient symptoms. How about if you see something like this? What do you do? So again, I can ask you a question. You can see that this is completely disformed and some deformity in the knee area. So X-rays, we had access to X-rays. You can just see this is a complete knee dislocation. So this is way different than just having patellar dislocation. This is a significant emergency and also a limb-threatening condition. So you have to be very aggressive. So what you do is basically check the pulses before you do anything, and check the neurovascular status. Oftentimes, because these are caused by multiple ligament ruptures, including ACL, PCL, MCL, they are not very stable. So then reduction, I've had multiple of these, and my N of less than 10, they're all been not difficult, because again, these are not, everything is just completely torn, so the reduction was not very difficult. The key is keep them after reduction in a stable position and posture, and just, you have to send these people to a higher level of care as soon as possible. If you don't have any X-ray access to the X-ray right away, which this was in a ski clinic, we had it, it's fine to try to reduce them gently. Just try it, and then right after that, check the neurovascular status before and after, put a knee immobilizer, and then they need to go to the emergency department as soon as possible. If there's any neurovascular compromise, that needs to be done as soon as possible, quick, even helicopter. But if it's like at least neurovascular, you see they're fine, the urgency is a little bit less. Okay, so I think I'm done with the knee. If you have any question at the end, you can just ask me. I can just discuss about knee dislocation as well. But I think, that's what, and there are different types of knee joint dislocation. It could be posterior, could be lateral. And as I said, usually there are multi-ligament injury consistent with these types of injury. So this is I don't know, I don't play golf. I don't watch golf that much, but a lot of you guys probably do. This is probably you guys remember. So just watch this in this amazing this guy just, yeah, so excited, just running, just running. Look at him and just twist it, and you can see his ankle, and that is not an ankle sprain, because you can see he puts it back. Let me show you one more time. Show one more time. Okay, look at here his left ankle. You see that? He just dislocated his ankle and he just pushed it back. So this is not typical. You don't see this typical. So, and he's walking on it. Ankle dislocations are less common, require significant amount of force, and almost always they are with different types of fractures. So they're not like, just put it back and I'm just going to go play golf. I heard this guy finished that day. I don't know how true that is, but again, it was very amazing. He just put it back by himself. Similar case. This was a 35-year-old lady, just coming off her car, and there was ice. She didn't see it, twisted her ankle, and just presented to urgent care with this. So you look at this, there's a significant deformity. So that something is going on. Neurovascular issue was intact. And then this is the X-ray. As you can see, is complete dislocation of the ankle, and also multiple fractures, including lateral and medial malleoli. So this is a typical ankle dislocation you see usually, with also their trimalleolar fracture as well. So this is after reduction, and reduction, again, these are not super difficult because multiple fractures, and it's very unstable. Then you put them in a splint for stability. This is another patient in the ski clinic. She came because she didn't want to do skiing. She was very afraid. So her husband said, "Oh, let's just do tubing." So tubing is much safer, I guess, not for her. So then what she did her tubing at the bottom of that slope. She was standing long, so the next person came and just basically hit her, and you can just see trimalleolar fracture and also dislocation as well. And this is the right picture, is just after reduction. This is also a post-reduction for her. So ankle dislocation. Remember, almost always associated with fractures, because we have so many involvement of the different bones and different joints. So I think, it's very rare to have no fractures with that. Just a second. Very common to have trimalleolar fractures. Some of you guys may not heard trimalleolar. What does that mean? We have only medial and lateral malleoli, but also posterior tibial, we call it posterior malleolus. So that's why I think we call it trimalleolar fractures. Usually unstable, and they need orthoreferral after stabilizing it. Obviously, check for neurovascular status. It's not a super urgent referral right away. We are done with the presentation. I intentionally made the presentation not very long. Just want to just go through a few slides and just go through the basics. And now, Julie, is it a time we can just go for the CAQ question and then open up to the question to people, or do you want me to just answer the question first?
No, CAQs would be perfect.
Okay. Oh yeah, so I'm just going to give you two examples. The first one, let me see if we can read the top part. You're just covering a football game, and there was an injury, and your trainer goes in, and she's signaling you to just go there. And based on your initial evaluation, you notice the patella is laterally displaced, and you ask athletes, "Have you had this before?" Said no. And your closest hospital is an ER is about 30 minutes away. And there's no ambulance at the game. It's a high school game, and you do not have any access to any x-rays, and assuming there's nothing else make you concerned about more serious knee injuries, you try, and after oh, thank you for doing that. And after gently reducing the patella, what would you recommend to follow up with care for this patient? Just a second. Okay, so these are the options. You can call 911, wait for the ambulance to arrive. You can place his knee in a knee immobilizer and transport him to an ER with a personal vehicle. You can place them in a knee immobilizer and just follow up with primary care physician in 2 days, or follow up with primary care physician in a week, or just send to ortho. I guess now we wait for your answers. Is that right?
We'll give it another few seconds.
Okay, thank you. Great, yeah. Okay, let me just close this. So the correct answer, yes, is 3. And why is 3? Because obviously this was not a significant injury, and did not need to, there was no neurovascular compromise. You did not need to follow up right away. For that, patient can follow up with the primary care physician in a couple of days. Usually the high school games on Fridays, so that they can go see their primary care physician on Monday. The reason I'm saying on Monday, because significant number of them, they have significant amount of hemarthrosis, and they may need to get a aspiration. That's why. Otherwise, you can wait a little bit longer. It's absolutely fine. You can also use hinge knee brace. You don't need to use for sure knee immobilizer, because the knee immobilizer it would be a little bit harder to have at some of the games. So, but hinge knee brace would be fine. And I would recommend a non-weight bearing or partial weight bearing as tolerated, but they need to see a primary care physician to do an x-rays, get an evaluation, and also if there's any concern about anything else based on x-ray, based on evaluation at that time, MRI may be needed. And based on what you find on MRI, they may need to basically just go see an orthopedic surgeon. But by no means this is any of these are urgent, and that can be wait for a couple of days. 1 week probably would be too much. One thing I would just cautious people, I'm not a huge fan of knee immobilizer for long time. Why not? Because I see sometime in clinics somebody had an injury, and they come like 10 days later, a week later, and they've been in knee immobilizer for a week, and the knee is so stiff, it's very, very difficult to manage it. So there's no major injury prevents you from just doing gentle range of motion. Obviously, if there was a fracture, stuff like that needs to be taken care of. You don't wait for a week anyway. But if there's a patella dislocation, it's okay to do a gentle range of motion after a couple of days, and do not put them in a knee immobilizer for a long time. Okay, great. So I have one more question. This is the same scenario, but a little bit different. So the same thing, football player, high school, get injured, and the trainer goes to evaluate and just signal you. You just go there. You just take a look, and just, expose the skin. There's no skin break, and you're seeing there's no deformity concerning for any major fracture, like for example, tibial deformity, or you don't see any femur deformity. And then what you see is that angulation of the tibia from the knee joint. So like the one I showed you. So you are suspecting this is a knee joint dislocation, and the closest hospital is about 30 minutes away, and you do not have any access to x-rays. After confirming, strong pulses, what would you do next? These are true situations. I had one patient like this. I think my second year after fellowship, I was covering a high school football game, and that happened to me. Okay, that is great. So I don't think calling 911 is a wrong answer, but I would say, just for the sake of just, multiple questions, if the pulses are strong after you reduce it, you can just, I don't think it's super, super urgent, like, minutes matter to send this patient to the ER. Yes, absolutely, patient needs to go to the ER because, you're concerned about any neurovascular, specifically popliteal artery, basically damage. Remember, yes, can happen, popliteal artery damage, people with knee dislocation. However, it's not 100%. It's probably about 30%. We don't have a lot of good studies about it, but just all based on case reports. But this is something, is very, very significant. You cannot just, miss it, and you cannot just, wait for it. So they need to go to the ER. And what we did with that patient, I remember I had a resident, and I sent the residents with the personal car to the hospital, but I did not take a picture. And I sent a resident. The residents went to the hospital, told the ER doc this patient had knee dislocation and was reduced. They didn't believe him. So then they just did an x-ray, it was fine, send the patient home. And I was just said, oh, come on. Anyway, so then long story short, patient a few days later went and had an MRI and showed multi-ligament ruptures, and ended up getting surgery for ACL. But again, sometimes, it's very hard to communicate. So I think that's why I think, I said, taking picture would be good to show, that somebody's just, covering that. Anyway, so yes, you can just send that patient. Let me just go to. Yeah, you cannot wait for this, as soon as possible. They need to be evaluated. The question about do they need to get any types of, vascular studies, including MR, arteriogram, or just doing angiography, CT angio. I think, these depends on the situation. I think, but you need to just send this patient and try to immobilize it, knee immobilizer. I think that's a very important thing, and check the pulses. Another thing you can do when you feel a pulse somewhere, just try to just mark it with a pen. So then next person just know where to look for the pulse, and they already had a pulse. And I think and always document about what happened, because sometimes we forget if you don't do it right away. What I do usually, I write a note, whatever document I have, I take a picture of that, because it's easier to communicate with the primary care physician, or sometime with the ER. So just have it at least as an image, so I can just communicate it with them. Yeah. Okay. So what is the reduction summary? Remember, they are rarely emergent. They're not very common, but if you see them, I think, it's very important to manage them appropriately. You can provide relief. It's a very good sensation when you reduce dislocation. Also, patient feels relieved. Maybe easier if you try to just do it before the muscle spasm sets in. Always check neurovascular status before and after for many reasons, and try to document as much as you can. X-ray is absolute after reduction. I know that sometimes you just reduce it and you said, okay, it's fine now, and patient is functioning okay, but you need to just do an X-ray, any types of, especially lower extremity, much more severe other than just the patellofemoral, but any other dislocation is better to just to have X-ray, post-reduction X-rays. Oftentimes, again, we all miss fractures, so you need to just also check for fractures. And remember, if something is strong enough to cause dislocation, can easily cause different types of fractures as well. I just want to thank the staff at Denver Health East Grand Community Clinic. It's a great clinic. We have a great team there, and fellows and residents. They have great time in terms of learning there. It's a great opportunity. If you have access to any high level of care like this, ski clinic in your state, or even just out of state, this is a great opportunity to learn. Now I'm open for any questions you have.
That was great. Thank you. I'll start off by asking what recommendations you have for individuals who perhaps haven't had exposure to a lot of lower extremity or upper extremity dislocations, how they can gain kind of confidence and skill in reducing those for future instances where they might come across them.
That's a very good question. It's very, very difficult in terms of get those patients. So my suggestion now, I think, YouTube is a very good resource. I'm not saying all the YouTubes are equal and they're all educational, and a lot of journals, New England has a lot of videos of different procedures. I'm not sure they have it for joint reduction or not. And also other thing is, if there's a joint you don't know, you never had it, or you don't know, and you're in the middle of nowhere, there's few things just as a general rule, I think, you need to understand. If you don't have any access to X-ray, so you don't need to do, you can do X-ray. Like, for example, elbow, okay, or fingers. So you can try it. What you need to make sure, you need to stabilize one part of that joint to be able to reduce it. You cannot move both part, proximal and distal part, the same direction, because they're both moving the same direction. So you need to have extra help. Somebody stabilize one part and you try to reduce it. Oftentimes what we say you need to make the deformity worse. For example, I'm just showing my finger. If you dislocate your PIP joint, usually is posterior. So if you only want to just with flexion reduce it, is very difficult. What you need to do, you need to just hyperextend that dislocation, pull it, and just pull it back. So this applies for a lot of our other joints. The same thing for ankle. So what you do, you just try to just, let's say this is I don't know, I can show it. Let's say this is a foot, and this is lateral, this is medial, and the foot is just going lateral. So what you do, try to have traction, make it deformity a little bit worse, and then just try to just pull it back. And as I said, those dislocations, unfortunately, they are very unstable. Reduction is not very, very difficult, but keep them in reduced posture. Sometimes it's just a little bit more difficult.
Yeah, I think that's great feedback. I always remember to recreate the injury to reduce the injury, and that can kind of help get you started if you don't know which direction to go. You mentioned non-weight bearing status, especially after a hip dislocation, at least if the patient is having pain or discomfort. How long do you generally advise them to be non-weight bearing, either for a hip or even for an ankle after the injury?
Very good question. Unfortunately, we do not have good evidence for any recommendation. So what all we have is somebody said 6 weeks, 4 weeks. I'm a huge believer of, if we don't have evidence, if you have a strong evidence, we should follow the evidence, no question about it. But if it's something like this, I think it's okay to just go with the patient's symptoms, with patient's discomfort. And we know that if we keep people in immobilization long, we create more problems. So as soon as you can just do at least range of motion without significant pain, is good to do that. So I would just say probably for hip, a non-weight bearing, especially if that fracture is going to be, they may need surgery. It's okay to wait for a week to see orthopedic surgeon. For patellar dislocation, if there's no avulsion, I would just say as soon as you can tolerate that, I think it should be okay. Even a couple of days would be fine. So answering your question, we don't know for sure. Just go with the patient symptoms, and as tolerated, be a little bit conservative. I think would be better than just put them in immobilization for a long term.
Wonderful. And then more of if there's evidence, great, but I was also just wondering about your personal practice, where the decision for more advanced imaging beyond X-ray, if initial post-reduction images are normal, are you making that decision to move on to a CT or an MRI based off of their repeat assessment in their primary care clinic, or are you doing it based off of their immediate pain post-reduction?
Great question. Again, it depends of which dislocation we are talking about. Patellar dislocation, patellofemoral dislocation, those are significant number of them. They may have osteochondral fractures and pathology, and MRI would be the best. CT, as you know, is good for if you're looking for a small bony abnormality, fractures we miss on x-rays. MRI would be fine, but like if you're thinking about acetabular fractures, which most likely they would need reconstructions, so a CT would be much better, because you're looking for the structure of the bone rather than just ligament types of injuries. Oftentimes, sometimes they need both, because, you can just do CT and just to look at the acetabular fractures. And also we need to know if there's any also damages to other soft tissue structure as well. So I think it's case by case. I think, yeah.
Wonderful. Well, those are all the questions that have been asked. So I don't know if you have any final words of advice or anything else you'd like to leave us with.
What I would just say, again, it's a great feeling. I have, residence fellows that when they reduce a shoulder, it's a great feeling for you and for the patient. You achieve something, you help somebody, I think is a great feeling. Always, always, always remember that there's a patient there and there's a person, and it's not a model for us to practice. So I've seen, unfortunately, a few times, one person tries to reduce it, it doesn't go in, second person goes, third person, fourth person, and we cause more damage. So there are sometimes they are not reducible, they're irreducible, and there's a reason for that. So if it's not going in, it's not because you don't know how to do it. Maybe there's something else. So then it's okay to just send them to the higher level of care, and maybe in a better anesthesia situation, and also more experienced people, they can just take care of that. So that's, I think I would just say that my point, try not to cause harm. So try to just, think about that person, which most likely is not getting any pain relief. You're trying to just reduce something is super, super painful.
Great. Well, thank you so much. We really appreciate it. It was an awesome lecture, great videos, and so we're really thankful that you shared your expertise with us tonight.
Thank you so much, Julian. Thank you, guys. And if you have any question, my email should be there, is on there. I cannot send you the videos. The PowerPoint is huge, but anybody wants a PDF of the talk, I can easily just send it to you. I'll send it to Andy, and if you can ask Andy for it, I think we'd be happy to just share with you guys.
Thank you.
Thank you so much. Have a good one. Good night.